This patient has a small pupil with poor red reflex due to the presence of vitreous hemorrhage. Prior to capsulorhexis, we performed viscomydriasis by injected a copious amount of cohesive OVD to expand the pupil margin. Then we performed a large capsulorhexis just under the pupil margin and carefully pivot in the incision. Full hydrodissection is important to free the nucleus from the capsular bag. Here we can see that the nucleus floats up and appears mobile. It is not compulsory to rotate the nucleus. Surgeons need to ensure the cannula passes below the capsule, or else they may induce fluid misdirection syndrome resulting in a shallow AC. Next, we proceed to phacoemulsification. We used the flip and chop technique in this case. Note that we slowly groove till an adequate depth before cracking the nucleus into two halves. Even if the pupil is small, complete cracking is still possible. Then we gently lift up the nucleus piece into the anterior chamber and further chop it. We recoated the anterior chamber with cohesive OVD prior to phacoemulsification. In this case, we used Helon 5 to help with pupil dilatation.
It is important to perform the phacoemulsification in a slow motion, with minimal turbulence, so that the OVD stays within the AC, to prevent AC collapse and pupil miosis. We can also reduce the bottle height, aspiration flow rate, and vacuum level, to achieve minimal turbulence in the eye. Other than the small pupil, this patient also has vitreous hemorrhage that resulted in very poor red reflex. It is difficult for the surgeon to visualize the posterior capsule. In this case, we advise making sure the phaco tip is always beveled up, to minimize the risk of causing posterior capsule rupture. It is also important to keep the phaco tip at the center to avoid iris aspiration. As you can see here, we also use the Lester hook spatula to help to open up the pupil margin for better visualization of the pupil. The Lester hook was used to hold the iris margin away with caution to avoid causing iris tear. In patients with poor red reflex, it is difficult for the surgeon to approximate the depth of the capsular bag, and even more difficult to know if there's any remained cortical matter. Therefore, slow and careful movement during cortex removal is warranted. We applied the POPS technique here. Surgeons can listen to the occlusion sound to guide them during cortical matter aspiration. We position the aspiration port so that its tip is under the anterior capsular fibers, pointed in the direction of the capsular fornix. Anterior cortical fibers are then occluded with a gradual buildup of vacuum. Once the port is completely occluded, there will be an occlusion sound heard. This is when the fibers are pulled posteriorly to detach them from the anterior capsule. After this, circumferential swiping movements are performed to further detach these fibers from the capsular fornix. Then, the vacuum is escalated, the aspiration port is brought to the center, and the fibers are aspirated completely. Here we can appreciate that the posterior capsule appears shining and smooth when all cortical matter was removed. Prior to implanting the intraocular lens, we injected copious amount of cohesive OVD for viscomydriasis effect, and to open up the posterior capsular bag. IOL implantation should be done after filling the bag well with viscoelastic, to prevent haptic snag on a lax capsule. During the viscoelastic washout, it is important to sweep around and keep the probe in longer, as the viscoelastics and nucleus piece may be trapped below the intraocular lens in small pupil. Lastly, we sutured up the corneal wound for wound stability, as we are going to perform pars plana vitrectomy for this patient next. To summarize, our first take-home message is to be generous with cohesive OVD in patients with the small pupil for viscomydriasis effect. Message number 2. Always make sure the phaco tip is beveled up and kept at the center to avoid iris aspiration. Surgeons are advised to perform slow phacoemulsification with minimal turbulence in these cases, to maintain the cohesive OVD in the AC, to prevent AC collapse and pupil miosis. Last but not least, remove the cortical matter by listening to the occlusion sound as guidance in cases with small pupil and poor red reflex. The posterior capsule should appear shiny and smooth in the event of complete cortical removal. Thank you.